So thank you everyone for being here. This is the second edition of our Revolution Cancer International Molecular Tumor Board. My name is Bassem Gwaley. Today I'm accompanied by a number of incredible individuals, including my co-host. So this is not something I do alone. Co-host, a couple of co-hosts actually. So Janaka Raman Subramanian, otherwise known as Ram, and Silan Barasan Maskamani. We also today are featuring Bhadresh Rami, who is an incredible drug discoverer, drug developer. We have Saba Gajdos, who is actually a surgical professor at the University of Buffalo. He's also head of hepatobiliary surgery there. He's a pretty remarkable guy. I've worked with him many times. Omar Shohan, another guy I've worked with, he's an interventional radiologist, also associate chair of the radiology residency at the University of Buffalo. And Ali Ukar, who owns a incredible healthcare access company in Michigan called Care Solutions USA. And so I think if you have any questions regarding access to healthcare, he's your guy. Our disclosures are here. Please know that what we're saying today is completely representative of our own opinion. They do not represent anyone that we are affiliated with. And we're going to jump right into today. We have a lot to cover, and I hope that you'll enjoy today. Actually, as I was putting together these slides, I had chills. Now, I admit that I'm a nerd, but what we're going to talk about today is remarkable. It is exciting. I don't think we're going to get better than we are today. What we're doing today is exceptional. So we're going to talk about PMV Pharma. We're going to talk about small cell lung cancer. We're going to talk about liver cancer, and we're going to have concluding remarks. So I think I told this story last time, and certainly you can refer back to the first tumor board we did. It's on YouTube. Please go back there and take a look at it. You can see our background. You can see the purpose behind this particular tumor board and why we think it's unprecedented, revolutionary. But at that time, I talked about my dad. And my dad, he's head of the signal transduction group at Promega for a long time. He had a lab before that at the University of Minnesota, has been studying cancer research his entire career. I grew up in the lab. I was 4 years old when I first saw a cancer cell, published first author on protein kinase assays that I developed at Promega with him when I was 16 years old, and then 3 papers before I was 20. And the bottom line is my dad and I, maybe one of the greatest gifts in my life that I've been given was the fact that my dad's a scientist. And so he'll send me 10 papers a day. We talk about companies all the time. We talk about pipelines. It's what we like to do. And so 2 years ago, we were talking about PMV Pharma, and we were talking about how they had this P53 inducer, and we wanted to get in when they had their IPO. So we knew that their IPO was happening in late 2022. And we wanted to buy their stock, right? And what happened when PMV Pharma debuted is they had set their IPO price at 18. But by the time it was available to the public, by the time my dad and I could buy it, because we're little people, right? We can't get in on the big stuff. But by the time we could get in the IPO, the stock price was already $35 a share. And that was like a couple hours after it IPO'd. So we weren't the only people excited about what we're going to show you today. Many people were, and you can actually see it went to 60 a share. Now the market itself has been cataclysmic the last 6 months. So please don't think that this share price at $14 a share is actually bad. In fact, I would say in this market, it's pretty good. So today we're going to talk a lot about P53. This is the focus of today. Now, I would say that in the last several decades, the two holy grails in cancer care, and certainly people can argue with me in this context, but the two holy grails have been KRAS and P53. Next time, 2 weeks from now, we are going to undress KRAS in a way that really hasn't been done before. And honestly, KRAS is now something that we're doing remarkably with, sotorasib, adagrasib, and there's a bunch of other companies, Revolution Medicine, Novartis, Roche, they all have KRAS inhibitors that are in trial and likely coming out eventually. But the other holy grail has been P53. And I think we're finally starting to get to a point where we can think about addressing this particular protein and mutations associated with it. So everyone knows P53 is the guardian of the genome. It's a tumor suppressor. Everyone knows that it binds DNA and activates downstream genes, and it's mutated in about 50% of human cancers. Now, there are numerous variants when you talk about P53 mutations. And I think the big thing that I really want to kind of get across today is that P53 mutations are not created equal. And we need to start getting out of that paradigm. We start thinking about P53 variants as being independent of each other. There are some that are actionable. There are some that are not. So when you see P53 mutations, which are quite common, you really, really need to start thinking about the fact that P53 mutations need to be considered in a vacuum. They really can't be considered as being created equal. And today we're going to talk about the P53Y220C mutation. That mutation is a destabilizing missense mutation, and it's seen in 1% of all solid tumors. You can see that here: breast, lung, pancreatic, gastric, esophageal, etc. Now, when we talk about PMV Pharma, what you can see here is that the pipeline entails various inhibitors that target specific variants. So they have PC14586, which targets the P53 mutation, the Y220C variant. They have another molecule that's targeting the R282W variant, and they have another molecule that's targeting the R273H variant. So you really need to start thinking about P53 mutations in terms of the specific variant. But today we're going to fixate on the Y220C variant. Now, what's amazing about what PMV Pharma did is they basically developed a drug that addresses the PC14586 variant and essentially takes a drug that's a protein that's mutated and that's essentially dysfunctional and makes it functional. It really essentially reactivates the protein and allows it to have wild type P53 function. The way it does it, right, is it basically has this molecule that intercalates into the crevice created by the Y220C mutation. You can see that depicted here, and essentially restores wild type function. That's remarkable. When you think about what we're doing in cancer, just think about the drugs we have in cancer. There's not a lot of drugs that we're creating that turn proteins on, right? We create a lot of drugs that turn proteins off, but we're not really creating drugs that activate mutated proteins. So this is a remarkable paradigm. It is a revolutionary shift in the way we think. And we're talking about P53. We're talking about a protein, a gene that's mutated in over 50% of cancers that we clearly know is involved in tumorigenesis. And now you've got these inducers that can do these amazing things. So when we talk about PC14586 and we talk about P53Y220C, what's pretty interesting, right, is in preclinical studies, they showed that if you have mutated P53Y220C cells and you give them this drug, you basically treat them with this drug, you can now induce P53 wild type activity. You get expression of MDM2 and expression of P21 when you actually add this drug to take the mutated protein and now give it functional P53 activity. In addition, if you look at the mice and you look at tumors in mice, so you take mice, you give them, inject them with tumors that have the P53Y220C mutation, and you give them this drug, you can see that you can inhibit tumor growth at the higher concentration. So here's the concentrations of the drug that they're giving. And at the higher concentration, you can see you actually impede tumor growth. So in preclinical studies, this drug actually looked like it was doing what they said it would, taking a mutated P53 protein and giving it wild type activity. And so PMV Pharma said, you know what, this drug looks really good in preclinical, it's time to take it into the clinic. And so they have a phase 1/2 open label, multi-center study to assess the safety, tolerability, pharmacokinetics, pharmacodynamics, and efficacy of this drug in patients with advanced solid tumors harboring a P53Y220C mutation. So what they're essentially doing in the phase 1, right, is they're looking to see if there's reasonable tolerability of this drug at various doses. So they have a dose escalation in phase 1, right? And then eventually when they find the right dose and they really look at their efficacy, then they'll take it in phase 2. And we're going to talk about the phase 1 component of this today, which was actually presented at ASCO relatively recently. So in this trial, this phase 1 portion of this trial, phase 1/2, I should say, they have a total N of 41 at the moment, right? And you can see that they're distributed across tumor types. So the vast majority are ovarian or pancreatic, some are in breast, right? But it's a pretty diverse patient population as far as tumors are concerned. In addition, you can see that the drug was very well tolerated. So there was side effects like nausea, vomiting, increases in LFTs. There was some anemia. There was an increase in creatinine, but in general, fairly well tolerated. This is an oral drug. You can see that more than 15% of people had these side effects. Now, aside from that, can you please turn off your, so whoever's on, can you please turn that off? Okay, sorry about that. We tried to make it so people could interact with us more easily, but unfortunately, we have people who are not muted. So anyways, the issue here is that there was dose-limiting toxicity in 2 of 41 patients, but in general, very well tolerated drug, and they decided that 1500 milligrams BID was their maximum tolerated dose. But just think about what we're talking about today. Just think about it for a second. We're talking about P53, a gene that people, a protein that people have been trying to address for a very long time. We're talking about taking a mutated protein and now basically treating it with a drug that induces wild type activity. Just think about what that's like, what we're talking about philosophically, and it's really mind blowing. So let's look at the data. Let's look at the results. So you can see here that we had an overall response rate of roughly 32% at the higher dose. So you can see that this is a dose dependent response. At 150 milligrams once a day, you do not see this response, right? But at 1150 milligrams POBID, you do, BID, you do see a very nice response, 32% partial remission. If you look at the actual target lesions, right, you can see that there's a significant reduction of target lesion volume at the higher doses. This is the 1150 to 1500 milligram dosing. You can see that the tumor burden has significantly reduced. At the lower doses, you do not see this impact. So this is dose dependent. This is an excellent response. In addition, if you look at the waterfall, you can see they had actually pretty good responses, right? There's a lot of stable disease here. There's a significant amount of partial remission. They did pretty well. If you look at the responses that they're seeing, they're actually quite durable. So there are several people still on the drug, progression-free at 9 months. So this looks relatively promising. This is a very interesting result. In addition, now what they also did is they looked at ctDNA, right? So they looked at cell tumor DNA, and they looked at the DNA that was specific for the p53Y220C variant. And they looked to see if they saw a reduction in this variant with their drug. And you can see that they see a significant reduction in ctDNA corresponding to p53Y220C at the higher dose. And so I think this is interesting. I do think that every single company doing clinical trials should be doing cell-free DNA in conjunction with those trials. We'll talk about that later, but I think it is a missed opportunity if you are not doing cell-free DNA at the same time you are doing your trial or some sort of genomic analysis. You have to do that nowadays. It's imperative, and we'll get to that later. When you look at some of the actual responses they were seeing in the clinic, here's a patient with stage 4 small cell lung cancer, extensive stage small cell lung cancer. And you can see here that when they treated this patient with the p53 inducer, this patient had a p53Y220C mutation. They saw significant reduction in the tumor burden here in the left kidney, and here it looks like in the lung. And so you can see here's the drop in tumor burden. So this is a very nice result. And so ultimately at ASCO and the company itself, they concluded that this drug that targets p53Y220C has an acceptable safety profile. They also feel like the exposure is generally dose proportional over a wide dose range and supports once daily dosing. So they're planning on doing once daily dosing. They saw preliminary efficacy in patients across solid tumor types harboring the p53Y220C mutation, and they're going to start looking at their phase 2. So I'm going to open this up to the audience. I would love to hear thoughts on this data. Let's take a comment or two. Please raise your hand if you'd like to give us a comment. Looks like Bhadresh has a comment. So Bhadresh, go ahead and unmute yourself. And
yes, Bassem, I think thanks so much. It's been an amazing presentation to see so many developments. I want to just highlight one point, add to what you said. The p53 field and the results that we are seeing in the clinical trial actually dates back to fundamental research in protein folding from the early 2000s. And the very early work in this field was done in Alan First's lab at Cambridge. And what we are actually seeing is p53, when it works as a homotetramer from a drug discovery point of view, from the molecular mechanism point of view, from the mechanistic pharmacology point of view, is the DNA binding domain of p53 is actually inherently unstable even in the wild type. Its normal melting temperature is 44 degrees centigrade as we speak in our body. And its half-life is only 9 minutes. So every 9 minutes that protein is getting turned over, especially the DNA binding domain. What these mutations that you highlighted, what they are doing is they're just putting that stability even below the room temperature threshold for us. And therefore, many of them become unstable, aggregated, and then degraded. And Y220C is especially interesting because it destabilizes the tyrosine to cysteine mutation, creates a void on the protein surface where the phenolic group of tyrosine is replaced by a thiol group of cysteine. That's where your molecule is fitting in, the small molecule activator and stabilizer. This mutation destabilizes by about 4 kcal per mole, makes 80% or more of the protein unfolded at room temperature in a normal patient with that. And it also, from a small molecule discovery point of view, it's ideal because it creates that unique crevice, and it's particularly amenable to filling in with small molecule activator drugs that can restore its melting temperature to 44 degrees, close to wild type. It's a particularly fascinating mix of what we see in the clinic, all the way as new resistant mutations emerging, how they tie into fundamental protein folding mechanisms and protein stabilization properties that have been studied rigorously. So this is actually a landmark study, and we are seeing amazing progress in the clinic. So thanks so much for highlighting this.
Oh, thank you, Bhadresh. I want to launch a poll here, so I'd like everyone to answer if they can. So we're going to launch this poll. So what do you think of the PMV Pharma data that we presented so far? And so you can either say, I'm so excited, I just can't hide it. You can quote the Pointer Sisters, and I actually just watched the Shania Twain documentary on Netflix. I highly recommend it. Or you can say that don't impress me much. And actually, when people brag to me and tell me how great they are, I typically think of the Shania Twain song. So I thought I'd put it on here. So let's just let this go for a little while, see what people think. Okay, so still getting some answers here, 17-6 for the Pointer Sisters.
Quite creative, Blossom.
I'm a big Pointer Sisters and Shania. Well, Pointer Sisters fan. I like Shania a lot. That Netflix documentary was remarkable. People should really see it. She's a special lady. Okay, 19-6 in favor of the Pointer Sisters. So let's move on. It's great. Thank you for that. Okay, so we're going to move on now and talk about a case. So this is what makes us unique, right? We go straight from pipeline into a case that really shows how the pipeline is manifesting. And so, Ram, please take it away.
Thank you, Basan. This is a case that is something I see quite frequently. And many of you who are practicing oncologists, I'm sure, have kind of faced the same situation. So this is a 69-year-old gentleman who presents with widespread metastatic tumor, turns out to be small cell lung cancer. And as you can see, he has a sizable lung mass with adenopathy, effusion, and also brain mets. And essentially undergoes what is the standard of care, which is carboplatin, etoposide, and IO agent for 4 cycles, and also received whole brain radiation treatment. So what you're seeing here is the biopsy samples, and I'm no pathologist, but one of the things that my pathologist explained to me when looking at cancer biopsy samples is blue is bad, pink is good. So there's too much of blue here, right? That's tumor cells essentially, and that is obviously a concern and makes our diagnosis. But we don't stop there. We look for markers that are specific here. Now, cytokeratin, as you know, is an epithelial marker. So that helps you identify this as an epithelial malignancy. And TTF1 is, it is a lung-specific marker. So you understand that this is a epithelial malignancy of lung origin. And again, before the point I should have made here is whenever you have a lot of brown stains, that means it's positive. So you see a lot of brown stains here for cytokeratin and TTF1, and I left out INSM1 for the lung. That's a neuroendocrine marker. So essentially you have a lung epithelial malignancy of neuroendocrine. I'm sorry. My apologies. I think I've unmuted myself just now. So just to go back, I think you
we
didn't
can
hear
hear
me.
you. Yeah, you're good. You just go to the next slide. And
Oh, did I just?
yeah, no, that was
Sorry.
you're right here. You're perfect. Perfect. Go here.
Okay.
Yep.
I didn't know when I have
No,
muted.
no, you're perfect. Go ahead.
Okay. So like I said, this is cytokeratin positive, TTF1 positive. So this is a lung epithelial malignancy. And INSEM1 or INSM1 being positive indicates it's of neuroendocrine origin. So you have a lung neuroendocrine malignancy here. So the likelihood is small cell or large cell, and that's usually a morphologic differentiation. A pathologist helps us with that. And this was a small cell lung cancer. So in this case, the biopsy was made at the left flank soft tissue. And the immunophenotype, as we saw, is consistent of the metastatic neuroendocrine carcinoma. And the TTF1 tells us that this is a lung origin, plus the CT and imaging clearly fits that morphology of lung origin small cell lung cancer. Sorry, went too fast there. So like we looked at, brain mets, standard of care treatment with carboplatin, etoposide, and atezolizumab, then goes on for atezolizumab maintenance, and also received WBRT. Normally, when it comes to lung cancer, non-small cell, we look for molecular testing right from the get-go, because that makes a big difference in how we treat these patients. But small cell, we obviously are behind when it comes to molecular testing and molecularly targeted therapies. Nevertheless, I see the value in doing molecular testing in all of my small cell patients. And here we have the report. You can see that it was, the PD-L1 expression is not very high, which is not surprising in small cell. The tumor cell score was 0%. Tumor infiltrating immune cells was 1%. And you have this TP53 mutation. Now, one of the classic features of small cell is TP53 and RB1 mutation, and at the same time, they have this neuroendocrine differentiation. On top of that, this patient also had a PIK3CA mutation. But I think the star, which kind of connects with what Bassam talked about, was this specific TP53 mutation with the Y220 missense mutation. So here, I'll pass it on to Salambarasan, who'll be talking about this specifically about this PIK3CA mutation.
Thank you so much, Ram. So like Dr. Ram and Basim mentioned about the T53 mutation in the small cell lung cancer, it's about 80%, right? But the thing is, we need to know whether the mutation, whatever the things it is available in the T50, whether it is a gain of function or loss of function, how it is losing its function. He already beautifully explained about how this stabilizer is going to reback the value of the T53 function back. So because of that particular Y220C mutation, it's lost its function. Whereas when we add this small molecule, then it's backing its gain. So similarly, whenever the genomic report comes up, so what are the things first we need to look at is where this mutation is located. So if you look at a gene of this PIK3CA molecule, so this mutation of H10478 is in the kinase domain. So this PIK3CA is going to code the protein of the P110 alpha molecule. So while during this mutation, the kinase function of P110 alpha function is going to lose. What's its main function it is going to be is that because of this particular mutation, it is going to activation mutation. So which means the downstream molecule of the PA3K signaling pathway is going to get activated. So if you look at here, the kinase molecule, this is the mutation we are talking about mainly, right? So it is majority of the mutations over here. The PA3K, one of the common hotspot mutation is 1047. Because of that one, it's gain of function and downstream signaling molecule is getting activated. One of the downstream signaling molecule is AKT molecule. Okay. Right. So if you look at this signaling pathway, so the receptor tyrosine kinase is here. So HER2 molecule and FGFR, all this receptor tyrosine kinase can activate this P110, which is the PA3K molecule. And then because of this activation mutation, what is going to happen is it is going to overactivate the AKT molecule and its downstream signaling pathway. So now we can ask this question like, because of this mutation, what exactly happening to the cell? basically. So if you look at the diagram over here, which is beautifully highlighted over here, H1047A mutation is increasing the cell proliferation. Increasing the cell proliferation in a much faster manner. This is no wonder. If you look at the small cell lung carcinoma, the cell proliferation will be hyperproliferation. So along with the T53 mutation, this PI3K mutation is making the cells to more proliferate faster. So which means that we may need to think about whether targeting this PI3K signaling pathway along with the T53 signaling pathway, the small molecule combination together, whether it can add any value to the patient or not, right? All those things we need to think about it. So from here, I will like to pass on to Basim to take over that how this mutation and the treatment strategy he is planning as a clinician, what he will do with this mutation. Now he knows both the mutations are gain of function mutation. So what to do with that one?
So Ram, I'm going to let Ram go do that. Ram, go ahead.
Thank you, Basim. So this is the COMET method that we have sort of come up with as part of the RCIMTB to look at how we approach the management options for these patients. Now, as you know, COMET's an acronym that stands for conventional systemic therapies, because we are medical oncologists. We are looking mostly at advanced stage malignancies. And so systemic treatment is a significant portion of that. And then, of course, operational surgery and then molecular-based options, which is the key reason for this meeting, is to find the molecular-based options, everything else, and trials. Now, of course, this is not a hard separation. These kind of sort of connect and work, collaborate with each other. Now, as you look through this figure, you can see that we come across different lines of treatment, and then either for progression or intolerance, we switch to different treatments, and therein we try to find where we can find the right option, whether it's a conventional systemic treatment, a surgery, or a molecular-based option. So when it comes to small cell lung cancer, standard of care essentially, as I said, is a platinum etoposide plus PD-L1 inhibitor is the standard of care. And this table summarizes the available regimens from the data from the Empower 133 as well as the Caspian study. They kind of were published recently, and Caspian followed a year after the Empower study. And the overall response rates, as you can see, is we're in the 60% for both regimens. And you can see that the median overall survival was 12 to 13 months. And the standard of care chemotherapy regimen was under 12 months. So until now, before these regimens came about, the median overall survival was less than a year. And with these regimens, we moved past the year. Now, you can argue that's a very incremental improvement, not a massive improvement, but still improvement nevertheless. And in small cell, we'll take whatever we can get. And the median progression-free survival is about 5 months, similar between both regimens. And you can see in some situations, the median PFS is almost the same as chemotherapy. But again, when it comes to immunotherapy, median PFS is not a very reliable marker. Sometimes we have to look at for second and third year overall survival percentages. And you'll see that by the second and third year, 3 times more patients survive when they are receiving Adazo or Darva with their chemotherapy versus chemotherapy alone. Because the 3-year overall survival is approximately 15% for these regimens, whereas with chemo, it's only about 5%. So that's conventional. So what other conventional options after you fail frontline? We have this long list of chemotherapy drugs. I'm not going to go through all of them. The key ones are lurbinectedin and topotecan, which are approved. And lurbinectedin approval was recent, and it's still awaiting the registrational trial data before it gets its full approval. Similar outcomes, it's anybody's choice. Some prefer lurbinectedin, some prefer topotecan. Topotecan can be difficult to give either as a weekly dose or a daily dose, whereas lurbinectedin is given once every 3 weeks. So there are some pros and cons between these 2 regimens. Surgical, generally, small cell is not considered an operable tumor, but there are exceptions to every rule. Obviously, when you have an early stage, like a stage 1 small cell, surgery definitely is their case. But in this particular patient, as you can very obviously see, this patient is not an operative candidate. So in terms of if they fail their frontline options, what about the targeted options? PIK3CA, this is a driver mutation from what Silambaram said. So there are drugs that are currently available in other malignancies. There are clinical trials, but I would be a little bit careful. Particularly if you have choice of trials and you have other second-line options available, particularly choosing PIK3CA inhibitors on their own, can be a bit risky, in my opinion, because they have consistently shown not such great efficacy in lung cancer, generally speaking. So I think we still have to go a long way in figuring out how we exploit the PIK3CA alterations in small cell lung cancer. Oligometastatic disease, this is something that we are learning. For example, in this case, we had WBRT. Even for brain mets, if you have like 1 or 2 or 3 lesions, not multiple, we tend to use SBRT more often than whole brain in small cells. So that's something shifting. Also, thoracic radiation consolidation is being considered in extensive stage if they have a good response after 4 cycles of chemoimmunotherapy. So locoregional therapies are definitely significant and are available for our small cell patients. What about clinical trials? What are the key things that are happening? Some of the key areas that we are targeting, one is DLL3. Many of you may know there was this drug called ROA-T, which was an antibody drug conjugate targeting DLL3, showed good response, but significant toxicity, fell apart. Now there is a new drug, an Amgen drug, which is a BiTE, or a bispecific T-cell engager that targets DLL3 and then connects to CD47 and pulls the T cells in close proximity. PARP inhibitors, not in all patients. Schlafen-11 shows some promise as a marker. If it is IHC positive, these tumors may be sensitive to PARP plus chemo. Liposomal irinotecan is also showing some promise in this area. And so those are some of the clinical trials coming about. But I think the key issue in this particular patient is that specific TP53Y220C gene mutation, which Basim laid out very beautifully. Very unique. So, when he did the poll, I actually was with Shania Twain when I chose it, and not because I don't like that trial, mainly because I just wanted to play the devil's advocate a little bit. Obviously, it's an early phase study, so some time, needs to go further before we have more mature data. But still, an early phase study, which is again not in small cell, it's a variety of tumors, having a 20 to 30% response rate that early in heavily treated tumors, I think there's room for cautious optimism. And the mechanism of action, again, is unique. And TP53 has been notoriously difficult to target. We've always been thinking from the kinase standpoint. So a different mechanism of action is great, I would say. And in fact, the one patient that had a phenomenal response, in fact, I think that patient's on top in the swimmer's plot in that study, was actually a small cell patient. This was a lady with small cell lung cancer, had been through the couple of frontline treatments, the second line treatment, and had failed, and with significantly progressive disease. And small cell, when they do progress, they struggle. And this patient went on that drug and had remarkable response. This was presented in ASCO. They actually specifically showed that case report and showed her radiologic response, which was quite promising to see that. So I think in terms of trials, targeting Y220C, if that patient has a mutation, has a lot of promise. Other trials we already saw, like the BiTE antibody, as well as combination with Schlafen-11 positive PARP plus chemo or liposomal irinotecan studies are definitely showing a lot of promise in this area. So how do we choose? The first 2 lines, we have standard of care. What do we choose? We have like 3 different options that we have in front. If you chose option 1, I think nothing wrong with that. That's essentially standard of care. But
Hey, Ram, what do you say about we open this up for a poll and then talk about it
I
after?
think that's a great idea. Why don't we do that?
Let's see what the audience thinks. I'm really curious. So we're going to have the audience tell us what we should do with this patient. So let me launch this poll. So you can choose option 1, 2, or 3. Here we're sequencing first line, second line, third line, fourth line, fifth line. Or you can choose 4, which means other. You don't like any of them. You might want to put the trial in first line, right? You might want to do trials throughout. So please don't be offended. There's no way to put every permutation for a treatment sequence on here. It's impossible. It'd be 10 slides long. So we'll give it another minute or two. Anyone else want to respond? So we've got 8 respondents. 6 of them choose option 2. 2 of them choose none of the above. And then nobody really chose option 1, which would be standard of care. Interesting. Well, standard of care outside of trials. Okay, cool. We'll stop the poll. Ram, why don't you tell us what you think?
So I'm not surprised by some of the results of the poll. Obviously, standard of care is not wrong in the front line, but we know that our patients with second line treatment, the improvements are marginal to you're just stabilizing it. And I personally chose number 2, simply because the reason is, if you think there is an excellent trial, one of the ways I think is, would you wait much later when their performance status really hits rock bottom and they may not be eligible for that study? That's always a concern that operates in my mind. And so a study that has shown early promising data, relative good tolerability, and your second line options are not necessarily great. So, you really have to husband your choices and, make sure we get them, open that opportunity for them when they are able to actually go ahead and participate in that trial. Because many times by the time you get to even second line, and definitely in third line, most of our patients, if not all, are not in any state to go on a clinical trial because they are so wiped out that performance status does not meet criteria. So that's the difficulty. Secondly, this patient has brain metastasis. Their outcomes are relatively poor. Chemotherapy has limited benefit there. So a targeted therapy, which may have better ability to penetrate the blood-brain barrier, is definitely a consideration for sure. So that's kind of what informs my choice. And I agree with the overall audience feedback as well. So the area of unmet needs, I think we have way too many when it comes to small cell. Even the front line, as mentioned in the first bullet point, median overall survival of 12.3 months. Nothing, great. From a physician standpoint, I have more tools to play with, but for the patient, it's tough. And this is what I was talking about, the Empower 3-year overall survival, 17.6%. It's 3 times better than what you get with chemotherapy, which is 5 to 6%. But still, that means more than 80% of our patients don't make it to 3 years. So we still have a lot of work to do. And the way definitely is with more clinical trials. But as a thoracic oncologist, I think there is more room for optimism now than later. And what are the studies that we would like to see? Obviously, have some of these targeted therapies move up front to the second line first and prove that they are effective there, and eventually get on to the front line itself. And as you can see, this is not going to be everybody. It's specific to the P53Y220C mutation. So we will need options for our other patients as well. Genetic counseling implications. I think this is my last slide. When it comes to small cell, it's commonly an environmental carcinogen-related malignancy, which is the carcinogen is tobacco smoke. So the likelihood of that being an inherited malignancy is low, so genetic counseling is seldom done. But I see in the long term, two places where they could be very effective. One, I think now we are understanding better about smoking behavior, and there could be some hereditary impact on that in terms of who smokes and who does not smoke. Now, these are early data and still a lot of research to be done before we can say who might be at high risk for tobacco smoking, which is a key risk factor for this cancer. And the other thing, if you have treated enough small cells, every now and then you'll run into this never or light smoker with small cell lung cancer. And the reason we believe is that something causes catastrophic genomic damage in small cell cancer. And commonly it is tobacco smoke. But in other patients, there are other factors that play a role. Could be a DNA repair damage, or could be other environmental toxin. And in those patients, I think genetic counseling definitely is a consideration, is how I would put it. So, any thoughts?
I think we'll skip this section just in the interest of time. So let's go to the next case.
Okay, so, I'm going to turn this over to Basim. Thank you, Basim.
Yeah, great. Thank you, Ram. It was really awesome. I appreciate that. So now we have a really special treat. That was one of the main courses, but we actually have two main courses today. This is a remarkable treat. So we are presenting liver patients. And I said patients plural for a reason. We're not just presenting one liver case at the moment. We're presenting 9 cases in one. We will very rarely do this, but we're doing this for a very specific reason. We don't actually have imaging on all 9 patients. They come from India. We got all these 9 cases from India, which is remarkable. We were very indebted to the doctors who submitted these cases. But you can see here, this is a representative case, somebody with stage 4 liver cancer that's metastatic to the lungs. You can see that depicted here. So this is 9 cases in one. They all had different etiologies for their hepatocellular carcinoma. A lot of people with hepatocellular carcinoma, as everyone in the room knows, is basically derived from cirrhosis. That's the primary risk factor. You can get cirrhosis for lots of reasons, right, including alcohol, hepatitis B, hepatitis C, et cetera. So many of these patients had hepatitis B, some had hepatitis C. We'll show that in a minute. When you look at the molecular profiles for these patients, and this is why we're presenting this, what you see is incredibly unique, right? You see a lot of patients with the same underlying molecular profiles. So they all have the cyclin D1 amplicon, that's cyclin D1, FGF19, FGF3, FGF4. They all have the same exact mutation in the TERT promoter, and they all have p53 mutations, many of which have the R249S mutation, 4 of them do, and then 4 of them have the R249M mutation. So this is remarkable. What we're about to show you, it's not new. People know that this pattern is there in HCC. We really wanted to emphasize it today. We think it's been ignored quite a bit. And in the context of the PMV Pharma data we showed, we really do think that people need to pay attention to P53, and we're going to demonstrate that people need to pay attention to this amplicon as well. We're going to propose novel clinical trials in this context, but what I think you're starting to see is when you look at these patterns, it's remarkable, but it's not just these 3 patients, right? Here's 3 more. So again, 3 more patients with the same profile. They do have some other findings. So some of them have a high tumor mutation burden, 10 mutations per megabase. Some people had an NTRK1 amplification, so 3 patients had that. But it's really remarkable when you look at it. Here's another 3 patients. So another 3 patients with the same profile, p53 mutations, many of which were R249M or R249S, the same cyclin D1 amplicon, and the same TERT promoter mutation. So you start to see this and you say, wait a second, what's going on here? Can we target this? Now, again, this is not a new discovery. This has been proposed in the past, but it is really compelling when you see it firsthand and you get 9 patients with this profile. You start to really say, wait a second, we should be looking at this therapeutically. This should not be ignored. We have to really consider what's happening here. And so when you look at it, you can see that all 9 patients had this amplicon. They all had a TERT promoter in the same exact TERT promoter, and they all had a p53 mutation. And so you can see that well depicted here. So when we look at the article published by Weinberg and Monahan, this is a seminal article, seminal review. These guys are, gods in the field, and we stand on the shoulders of giants. That's what we routinely do in science and in medicine, and I'm certainly no different. You can see that they have the hallmarks of cancer, right? And you can kind of go through these yourself. You probably have already seen this, but you can evade growth suppression. You can try and address the ability to replicate without fail with replicative immortality. You can avoid immune destruction, et cetera. So you can see we're going to talk a lot today about genome instability and mutations. We're talking about evading growth suppressors, and we're talking about enabling replicative immortality. That's really what we're talking about with the mutations we just talked about. So I'm going to turn it over to Silvan, and Silvan's going to be a little bit quick here because we have a lot to cover.
Sure. Thank you, Basim, actually. So like Dr. Basi mentioned, all the 9 cases are very, very unique cases. So when the clinicians seeing many mutations are which one to target? And when we go about it, actually, when too many are there, what to pick up first, and what exactly it's doing for the tumor, and what is the story it is trying to tell out of it, actually. Right. So the first thing I'm going to pick up is the chromosome number 11, 13.3, because this is the one region where 4 amplicons are getting together amplified, basically. So the chromosome number 11, if you look at the bottom here, CCND1, FGF19, FGF4, and FGF3. All these 4 genes are sitting next to each other and expressing as a co-gene, like co-expression together. So what exactly it is going to do in this cancer is that, so majority of the cancer, like 5 to 7% of these HCC cases are going to have this mutation, basically. So what are the stories we are going to derive from? So first, the cyclin D1. So now the cyclin D1 recently have been published that it can be considered as the universal biomarker for the immunotherapy resistance, but yet to reach that stage. But another thing, what exactly it is going to do is that the cell cyclin D1, right, activates the CDK4,6 in C4,6 from G to S transition. So that's a cell cycle controlling the first step in the cell cycle. So when the CCD1 is amplified, it can possibly overturn the cell cycle again and again. It will enter into the cells. So that's why the hepatocellular carcinoma is going into hyperproliferation state mode. So is there any possibility whether we can use the CDK4,6 inhibitor for this patient? Dr. Basim will explain a little bit later. So the next mutation we are going to talk about is the FGF19 overexpression. So if you look at the fibroblast growth factor, so what exactly generally it used to do is that it's used to activate 2 different signaling pathways. One is the RAF signaling pathway, another mTOR signaling pathway, and other PI3K signaling pathway. These are the 2 major signaling pathways it is going to drive. And by driving this pathway, what exactly it will do is increase the cell proliferation and increase the angiogenesis and anti-apoptotic. More importantly, it will induce the invasion. The tumor size is going to be bigger, right? So these are the things, few things it is going to do, the FGF19 overexpression. So if you look at the tumor size of the patient who have the FGF19 mutation, just like I mentioned, the hyperproliferation is one side, it's going to increase, and also it is also going to increase the tumor size. So when the patient HCC patients, they are having the FGF19 mutation along with the CCND1, so they are going to have the shorter cell survival, and also their cell volume, the tumor volume is going to be in a higher manner. So one side FGF is increasing the tumor size, and along with the CCD1, it's increasing the cell proliferation. So you can see that both together, it's even more detrimental. So when we going to correlate the FGF amplification correlation, there is an interesting study. It's showing that the patient, when the population having the FGF19 amplification, they will respond beautifully to sorafenib. So by doing the CGP, we can be able to understand this one. The patient is going to having the FGF19 amplification, means they may respond to the sorafenib. So you can go back and identify exact the population which they will respond to the sorafenib, and then go for the further treatment. And the FGF of inhibitors already is failed in this treatment. So we need to see whether any other combinations of therapies like lenvatinib and all those things, whether it is going to work or not. Because FGF, the lenvatinib is FGF pan FGF inhibitor, whether it can be used up in these settings or it's another $1 million question we need to ask about it. So if you look at the patient, pre-treated patients before treatment, after treatment with the sorafenib, you can see from here, the tumor size is reduced already. So which means that the patient of hepatocellular carcinoma with FGF19 overexpression, they will respond beautifully to the sorafenib. That's the one inference message you can take from this genomic profiling based treatment case. Okay, so another one more molecule we are going to discuss in this one is the P53. So earlier we have discussed P53 in the small cell lung cancer, here in the hepatocellular carcinoma. So as I mentioned earlier, each P53 mutation is totally different. So in this case, the P53 mutation we are talking about is the R249S mutation. Right. So when the P5324S9 mutation is there, the cell proliferation is going to increase along with the cell cycle. So it's a gain of function. First, as mentioned earlier, First thing, we need to identify where the mutation is located, which domain of the particular protein is located, and then because of this mutation, whether it's a gain of function or loss of function of this particular one. So here it's a gain of function. So if it is gain of function, exactly what phenomena is going to control in the cancer, right? So the cancer here it is controlling is the cell proliferation. So look at the diagram over here. So this is P53, the R249S mutation in the DNA binding domain over here. And you look at the right-hand picture over here, control how the cell proliferation. And when compared to the R249S, how the cell proliferation is much faster. So which means that along with the cyclin D1, this P53 is driving the cell proliferation much faster phase. So you can see over here compared to control, and the graph over here, the cell number is gradually increasing. Not only that, next thing, you look at the down picture of the D1, the control, you can see this is a cell migration assay, right? So how fast the cell can move towards another area, which means that the tumorogenesis and the one metastatic region from one region to another region. That's why the patient with this mutation, they will develop micro hematoblastoma in different regions. So thereby the patients may not be eligible for the TASE program or TAR program because there will be already multiple micro lesions are there. So if you look at the control towards the R249AS, the cell proliferation is much faster, and also the migration and invasion is also much faster. So these are the few information this P53 R249AS is bringing the story for us. So the next important mutation we are going to discuss about is the TET promoter mutation. So even though there is no clinical value for say to target this treatment, right? But what are the other stories we can derive out of it? First thing, when the TET promoter mutation is there, it will be in the 60 to 90% of the HCC population is going to have. More importantly, the viral infection. The viral infection is the key here. So in the promoter, the C1 minus 124 region, the virus will incorporate into this one to amplify this proliferation. So that's why it's very important to activate the fetal form of the TET promoter. So the fetal genes will start to re-express. So if you look at the image over here, when compared to the normal liver, when the liver with this hepatocellular carcinoma is infected, in the hepatocellular carcinoma, the HCV or HBV, so the TET promoter is going to get activated. So when the TET promoter is getting activated, it is going to re-express the fetal genes. So which means the fetal genes, all the genes will be expressed to show the earlier hepatocellular carcinoma towards the advanced stages, much faster phase. Right. So now I will hand over to Basim to take it further from the clinician's view, what he thinks about this mutation, how he will handle this mutation from day-to-day life.
Thank you so much. That's great. Sorry about this red line, guys. I apologize. I'm not exactly sure how that got there. I'm really sorry about that. So the bottom line is we're going to talk about conventional systemic therapy is operational. We're going to go through this COMET algorithm again. So here we're talking about conventional therapy for patients with HCC. So when we talk about first-line treatment, so we're talking about first-line treatment here, you can see that the options are sorafenib, lenvatinib, Tecentriq Avastin, and I think that durvalumab, tremelimumab will be approved this year based on the Himalaya trial. I would expect this to be approved this year. Now, please take that with a grain of salt, but that's my expectation. So when you look at the data here, you can see that sorafenib has a pretty abysmal overall response rate, but relatively reasonable stable disease response rate. So I should say abysmal PR response rate, but pretty reasonable stable disease response rate. This was the first drug really that did anything in stage 4 HCC back in 2008. This was revolutionary back then. I remember when we were treating patients, we were excited to at least have an option. You can see it really only takes median overall survival from roughly 8 months to 11 months. But what you'll see a little bit later is when you look at other trials being done, sorafenib overall survival, median overall survival seems to be a little bit larger. It shows you that there's some noise in clinical trials. I contend that all the time. I think there's going to be a real role for real world evidence. We already know that. Lots of companies in this space, and so we know that. But when you look at median PFS, you can see an extension from 2.8 to 5.5 months. Now, lenvatinib came onto the scene in 2018. You see a higher response rate, roughly 24% versus 9.5%. You see a slight increase in median overall survival. This is nothing to write home about, but a slight increase in median overall survival. And certainly if you've got HCC, that 1.3 months matters, right? Every day matters. And so I've been in the room where I've had patients with stage 4 disease, and they're begging us just to try and give them one more minute so they can be with their 7-year-old child. And so I completely get that. It matters. At the same time, this is not earth-shattering. We would love to see something much more earth-shattering, but credit to Lenvima, credit to the company that makes it. We're very pleased with this. But with that said, you can see that median PFS went from 3.6 to 7.3 months. So a lot of people like Lenvima. I do use it. I don't use it in first line. We'll come back to that. Now, with that said, Tecentriq plus Avastin is my preferred first-line option for patients who are Child-Pugh class A. So we do kind of put people with HCC in categories. We grade the severity of their disease. You can do a MELD score. You can do Child-Pugh A, B, C score. That's fine. But for Child-Pugh A disease, my preference is Tecentriq Avastin. I like attacking this cancer in two different ways, right? Sorafenib, lenvatinib, they're both VEGFR inhibitors. They both inhibit angiogenesis, so new blood vessel formation. Tecentriq is a VEGF inhibitor. It also does the same thing. But I like, on top of that, being able to use immune therapy in first line. Tecentriq is immune therapy. So I like this dual mechanism attack. I really like this regimen. Overall response rate, 27.3% versus 11.9% for sorafenib. Again, you can kind of see a little bit of noise in the sorafenib data. With that said, median overall survival when they presented their data for approval, I'm just looking at the data that the FDA used for approval, was not yet reached with Tecentriq Avastin. It was 13.2 months for sorafenib. And you see the noise here. You can see that there were other things you can do in second line. You can start to see the noise in some of these trials when you look at that median overall survival data for sorafenib. You can see that median progression-free survival went from 4.3 to 6.8 months. Now, when we look at what's going to happen with durvalumab and tremelimumab, you can see they have a 20% overall response rate. That median overall survival is a little bit higher, 16.3 months versus, 16.34 months versus 16.56 months for durvalumab alone versus 13.7 months for sorafenib alone. So you can see that here. It's interesting actually that the overall survival was not drastically different initially for durvalumab tremelimumab versus durvalumab alone. But I do think that this is going to get there in first line. I do think we're going to see this, and it's a nice additional option to have. But these are the three options right now that are FDA approved. I expect this to be approved, but you can see this is the first line setting. Now, I want to be very clear about something. There was a recent trial published looking at looking at cabozantinib plus Tecentriq versus sorafenib alone, and cabozantinib plus Tecentriq had a roughly 15-month overall survival. Interestingly enough, in that study, sorafenib had the same median overall survival. So we'll see what comes of that. I do think that's interesting data. To be honest, we'll just use Tecentriq Avastin versus cabozantinib plus Tecentriq because I like Avastin safety profile more than I like cabozantinib, and I think the efficacy is very similar. If I was the company running that trial, I would have gone head-to-head with Tecentriq Avastin. It wouldn't have made sense for Genentech who makes Tecentriq, but if you make cabozantinib, it might have made sense. Now, with that said, I'm probably going to stick with Tecentriq Avastin in first line. In second line, there are a lot of options, but many of these are garbage, and I say that respectfully. But I think a lot of these drugs are garbage in second line. I do not like cabozantinib's 4% overall response rate. I do not like ramucirumab's 9.5% overall response rate. I don't like regorafenib's 11% overall response rate. I can see that the PFS is a little bit better, right? You can see it goes from 1.5 to 3.1 months. The median overall survival is decent for the people that respond, right? It's a pretty decent drug. And when you have nothing left, that's fine. I think it's great, but I'm not a huge fan of using these drugs in second line HCC. I do use lenvatinib in second line HCC after I use Tecentriq plus Avastin, but I'm not happy with any of it, right? I'm looking for better options. We need better drugs in this disease. Ipi/Nivo is a very good option here. You see a 32% response rate. The problem is if you're using immunotherapy in first line, use Tecentriq in first line, the patient really can't get Ipi/Nivo in second line. It doesn't make any sense. So Ipi/Nivo, in my opinion, has had a very hard time finding a foothold in second line HCC despite being a good regimen. Would have been better for them to get into first line like durvalumab and tremelimumab with the same mechanisms of action are doing currently, like I just showed. So those are our options from a conventional treatment perspective. Let's turn it to Saba Gajdos, who's amazing. He is, like I already said, a clinical professor in surgery at the University of Buffalo. He also is head of hepatocellular surgery there. So Saba, can you speak to how you look at surgery in HCC?
Yes, sir. Thank you very much for the kind introduction, and I appreciate everybody's time here. So looking at HCC, you basically have to categorize the patient. Is this happening in a setting of cirrhotic or non-cirrhotic patients? So here in the United States and most of the Western Hemisphere, we're looking at non-cirrhotic patients relatively or very infrequently, representing only about 10% of the population that presents with HCC, as opposed to 90% or 90+% of patients present with underlying cirrhosis. And obviously the importance of that, if you look at non-cirrhotic patients, liver transplant is not really an option for you, or not really a great option for you, or even an opportunity. So then you would be looking at resection. When you look at patients with cirrhosis, just like you mentioned, first and foremost, you have to look at a number of things. You have to look at the patient's performance status. You have to look at the disease stage. You have to look at the size of the tumor and number of tumor. You guys must have heard about the Milan criteria, which still is a very useful guide. Extended Milan criteria, like San Francisco, tumors up to some Milan criteria, single tumor up to 5 centimeter, up to 3 tumors not exceeding the 3 centimeter, or San Francisco extended criteria is up to 8 centimeter for a single lesion. So those are things that are being looked at for transplant patients. And like you mentioned, you have to get on a transplant list, and you're going to be based on your MAD score and various other factors, child VBC, but most of the MAD score, you're going to be put into a low, intermediate, or high category in terms of likelihood of being transplanted. The problem with transplant is availability of organs. Now, that's the situation on the Western Hemisphere. On the Eastern Hemisphere, this is still an ongoing debate. What do you do with patients with cirrhotics who also have underlying liver disease? So resection is another option. In terms of candidacy for resection, in many aspects, it's similar to transplant. Up to 5 centimeters said to be the best. That being said, patients over 5 centimeter primary single tumors can also be resected, obviously at a high risk of recurrence. You also have to look at the underlying liver function, especially in cirrhotic patients, because resecting them over 40–50% could be ill-advised, secondary to residual liver function not being adequate, and patient could potentially suffer various degrees of fatal liver failure postoperatively. The problem with those scenarios are that we still do not have actually great way of assessing that. So I would be very careful about resection in cirrhotic patients beyond Child's A category. If you look at even aggressive Eastern Hemisphere resection series, the actual number, there's no patients that undergo resection per se. With Child C, Child B, there are hand-selected cases, and the great majority are Child A. Another emerging treatment options, which are actually becoming more and more favorable, is actually ablation. So there's various ways of doing ablations. Alcohol ablation is kind of not something that we do on the Western Hemisphere. RFA, radiofrequency ablation, has been established superior to alcohol ablation. But many companies actually stopped making RFA machines and use really microwave. So the best candidates are patients with a 3 centimeter or less tumor. You can ablate up to 4 centimeter. As per company guidelines, there's no real upper limit. But again, when you look at the results, over 4 centimeter recurrence rates tend to be higher. If you look at risk of recurrence and survival, if you know that this is a disease that will come back, 5-year survival in transplanted, selected transplanted patients can be 70–90%. In a resection series, similar in terms of the risk of recurrence. The average time for risk of recurrence between these treatment models is also not so drastically different. Many patients recur within 2 to 3 years after treatment of the primary. The benefit of ablation in many centers can be done laparoscopically. It is done by the surgeon or interventional radiology. So the recovery time is remarkably short. Most of our patients go home the next day. We haven't really ventured into sending them home the same day, although some people potentially could. So that would be the primary surgical treatment in a very small nutshell.
Thank you so much. Obviously in stage 4 disease, really no surgical option here. That's really amazing. Thank you for that beautiful recap. I appreciate that.
One sentence on a stage 4 disease, you're correct. Widespread stage 4 disease is not a candidate. Have I resected well-selected stage 4 disease patients presenting with isolated metastases, which is resectable, and the primary is controlled? Yes. Retrospective data, no high quality evidence for that.
Yeah, it's a really important distinction. I appreciate you making that one. That's really, really important. Let's just say for these 9 patients, really no great surgical option, but that's a very important distinction, absolutely. So when we talk about molecular-based options, this patient has a relatively high tumor mutation burden. Some of them do, with a tumor mutation of 10. So you can see that when you have a higher tumor mutation burden, there's a higher correlation with immunotherapy response. So these patients here, you can see the higher the tumor mutation burden, the higher the response on average. Now that's certainly not a set rule. That doesn't always happen. There's numerous exceptions to that. But the bottom line is it suggests that a patient might respond to immune therapy. So you might want to use Tecentriq in first line or durvalumab plus tremelimumab in first line in the patient with a TMB of 10. But that's, neither here nor there. The idea behind it is that when you have a significant amount of DNA mutations, you get neoantigen formation from those mutations that are recognized by the immune system cell as foreign, and the tumor cell is eradicated. When we talk about additional molecular options for this patient, we can really think about CDK4 inhibitors. We'll talk about it in a minute. We could talk about lenvatinib targeting the FGF19 sort of amplification. We could talk about the H-TRP mutation, how there's UV1 in melanoma. We'll talk about that a little bit later. So I want to now turn our attention to Omar Shohan, who's a phenomenal interventional radiologist. He's also the associate chief of the residency program for the University of Buffalo for radiology. So please, Omar, talk about local regional options for us.
Hey, thanks, Boz, and thanks for having me on for today's talk. So I just kind of focus this on stage 4 disease for HCC. Again, Y90, radioembolization, transarterial chemoembolization, they're kind of reserved mainly for the intermediate class of patients. And when it comes to stage 4 disease, there's really a limited opportunity to use this. Most of the studies that have shown really kind of compare taste to either taste to nothing, so either palliative versus taste, really haven't compared sorafenib with taste. But in terms of taste, they have used it in the setting of minimal portal vein invasion. And when it comes to palliative care, there was an overall survival benefit from 7 months to 2 months. When they compared TARE with sorafenib, so again, there's 2 different types of Y90. There's glass and resin. So Spheres is made by Sirtex down in Australia, and then there's TheraSpheres, which is owned by Boston Scientific now, and that's glass. So there's minimal differences between the two. But again, for those who don't really know what radiation or transarterial radioembolization is Y90. It's a small little particle that emits beta radiation for about 2.5 millimeters in depth of the tissue. It works for about 11 days, and then it kind of lingers on during the duration of the patient's life. So most of the comparison trials just compared it with sorafenib. So whether they did Sirtex with just sorafenib, they saw that there was just a little bit of overall survival benefit with sorafenib by 1 month, but there's fewer side effects with radioembolization compared with sorafenib. Now they've done a trial that compared TheraSpheres plus sorafenib and then sorafenib alone. And there is an overall survival benefit with TheraSpheres plus sorafenib by 1 month from 12 months compared to 11 months. And there's fewer side effects, which just add the additional benefit of Y90. So there's, again, limited use in terms of giving the patient any benefit. You might buy them another month. But when it comes to side effects control, there is some benefit. So if you're looking at trying to just make somebody more comfortable, radioembolization or transarterial chemoembolization can add some benefit. But again, it's a very narrow window, a very select patient population you benefit from it.
Thank you, Omar. I really appreciate that. Thanks very much.
Mm-hmm.
So when we talk about clinical trials in HCC, there's roughly 156 ongoing in stage 4 HCC. There are many variations on a theme. A lot of people trying to use VEGFR inhibitors, a lot of people using CTLA4 inhibitors like tremelimumab, like ipilimumab. There's a lot of PD-1, PD-L1 inhibitors in trial. Honestly, lots of variations on a theme. There are some novel mechanisms of action: CDK2 inhibitors, CDK9 inhibitors, Toll-like-3 receptor inhibitors, IL-8 sort of antagonists. There's DKK1 antagonists, etc. So I should say Toll-like-3 agonists. But the bottom line is, we are seeing a lot of different trials in HCC, a lot of people trying to get their drugs into HCC. I think that HCC has laid waste to a lot of drugs in trial. It's a tough disease to treat. So there are some cellular therapies. They were a little bit underwhelming from my opinion, but the GPC3 CAR-T was interesting. There's a Morpheus trial that really looks at a number of different immunotherapy sorts of drugs in HCC. I think that was interesting. So when we start talking about treatment cartography, there's a bunch of trials. So again, we basically look at our options in a COMET-based algorithm, and then we say, okay, how are we going to sequence them? I'm going to ask you guys to sequence them in a second, but these are our options. We kind of say, okay, let's just now take them, and now let's build a sequence. So here we have option 1. looking at Tecentriq plus Avastin. I included radioembolization here because I do a lot of Y90 whenever there's liver predominant disease. So if I've got a patient with stage 4 hepatocellular carcinoma and most of their disease in the liver, I'm immediately going to go to radioembolization or TACE because I don't see any downside in it. It's fairly minimal risk. Beggars can't be choosers in this disease. I know we're waiting on trial data, but I oftentimes will use it as an adjunct to systemic therapy. I just don't want to sit there and watch my patient die. I just won't do it. And so here's Tecentriq Avastin in first line. Then you got a trial here, Tecentriq Avastin here. And then, so I want to know what people want to, what people think here. So I'm going to set this up. We're going to have another poll and you guys are going to decide on what we do. So let's launch this poll. So there's 4 sequences here. Please select which sequence you want to use. I feel like I need like Jeopardy music or something when we do this. I'll find some, maybe I'll do Shania Twain music when we do this or something. All right, so I think we got some nice responses here. I know it's hard to look at this and you know, it's a little messy slide. I admit that and I apologize. But we tried to set you up. We tried to give you the data, try and give you a feel for what the options are. And so, you know, it's really what we do, right? It's not rocket science. You kind of just walk through the data. What does median overall survival look like? What does PFS look like? Would I want to do better here? So great. So we got 7 responses. Thank you for that. Let's share the results of this. So you can see here that basically 3 people like option 1, 3 people like option 2, and then 1 person liked option 3. So yeah, I think, you know, option 2 really is standard of care here probably. And so I think that's perfectly fine. I think option 1 is great. Honestly, if you can get a trial, you're going to be trying to get on a trial. And so we'll talk about it in a second, but I think all of these options are great. I don't think there's any real wrong answer here. You know, some experts might disagree, but I would challenge them to show me the data that suggests they were right. So when you talk about HCC, we talk about this is really an area of unmet need. So we have this feature for drug developers, right? So the world is moving to a place where making a drug to a protein is going to be relatively easy in the world of computational biology. You can actually just look and see what's happening in pharmaceuticals now, right? In the biotech space, pretty much every protein you can think of, people are trying to develop a target, trying to develop a drug for it. So the key will be in combination therapy, how do you take your drug and mix it with another one? And the key will be in identifying which target to really focus on. Now, and also identifying the tumor to be in, the space to be in, right? And so we have this feature for drug developers and for pharmaceuticals, and I'm telling you, HCC is a huge area of unmet need. It is the 6th most common cancer worldwide. It is the 3rd most common cause of cancer-related mortality worldwide. It's the 5th leading cancer killer in the US, and all lines are open here. The current treatments are relatively underwhelming. Yes, I like Tecentriq Avastin, but that's a relative likability there, right? It's just, we need better options when you're talking about overall response rates of 25% and median overall survival of 15 months. That's nothing to write home about. I recently saw an interview with a key opinion leader who said we're doing great in HCC. Absolutely not true. We are not doing great in HCC. We need a lot of help. And I just proved it, right? I showed you the data. Median overall survival is 15 months. Yeah, relative to 2007, we're doing great, but we still suck at HCC and we suck across every single line. So we need help. If you're a drug developer, absolutely, absolutely look at HCC. It's low-hanging fruit. If you're a pharmaceutical company and you have a new molecule, see if you can justify using an HCC. It is low-hanging fruit. Here's a couple trials that we propose. Now, this is, I think, a very interesting feature we are providing. We're not only saying, hey, this is an unmet need, but now we're also saying, hey, here's some trials to think about. So this first trial is Tecentriq plus Avastin plus minus a CDK4/6 inhibitor in the first-line treatment of people with metastatic HCC with this amplicon and with proficient RB1 expression. So we are moving to a world, right? We're moving to a world where treatments will be very much personalized. We'll be looking at your entire profile and we will say, okay, you have this mutation, this amplification. How do we target you in combinatorial fashion to really give you the best survival rate? And so if you're really thinking about doing that here, take Tecentriq Avastin backbone, which is very well tolerated. You can add drugs to this backbone. It's an incredibly well tolerated backbone. Add your CDK4/6 inhibitor, but do it in people who have amplification of this cyclin D1 amplicon and also have proficient RB1 expression. I'll explain that in a moment. But really start looking at cell-free DNA, really look at the genome and target clinical trials in that way. Now, what I would do here, to be honest, if I'm a company, I would do all comers, right? I wouldn't just restrict the trial to these patients with this cyclin D1 amplicon, all comers, but I would stratify based on the amplicon, right? And see what sort of signal you can get. It doesn't take much to get approved in HCC, and the rationale here is too compelling. You could do the same thing, right, with ipilimumab plus nivolumab, or durva plus tremi. Just again, do your CDK4/6 inhibitor in first-line treatment, again, with the amplicon, with RB1 expression. I would do all comers, and then I would stratify based on the amplicon, stratify based on RB1 expression. Ipi-Nivo, also very well tolerated in general. I don't think it would be a problem adding a CDK4/6 inhibitor, just based on my experience. I think that would probably be pretty safe. You could do a crazy trial, and now we talk about a crazy trial, right? You could target the HTER promoter with an HTER vaccine, so you could use UV1 that's used in melanoma. You could add Tecentriq Avastin. You could add your CDK4/6 inhibitor, and now you can add a p53 inducer targeting R249S, and we're going to talk about that in one moment. But you would do concurrent liquid biopsy here. You'd follow the patient all the way across, and now you've got these crazy trials. You start thinking, okay, how can we personalize trials on steroids, right? How can we really target patients in a way that's profound? Another trial you could do lenvatinib because of that FGF19 overexpression, right? It's an FGFR1 through 4 inhibitor. You can now use it with pembrolizumab. You can add a CDK4/6 inhibitor. I said pembrolizumab only because that's already approved. Lenvima plus Keytruda is approved in renal cell. We know it's safe. It's also approved in endometrial. We know it's safe, right? So there's no reason why you can't try it. And so you just use this regimen. You use it with the CDK4/6 inhibitor. Again, all comers, you stratify based on the amplicon, and there you go. And so that's where we'd be. Now, why did I talk about RB1? Well, sorry, let me back up for a second. I'm not a genius. This is not like revolutionary stuff, but I will say no one is proposed the trials we're talking about, at least no one's doing them. And when you look at CDK4/6 inhibitors in HCC, it really hasn't been done very much. Palbociclib, which is Ibrance, was done in 23 patients, phase 2, single agent in advanced HCC. That trial is complete, but there's no results. I couldn't find them. Ribociclib had an N of 5. They looked at it with chemoembolization. The sponsor actually withdrew support. Abemaciclib had an N of 7, phase 2 trial with nivolumab in HCC. Again, nothing to write home about, really hasn't been studied. Again, look, they really did make sure that RB expression was there. And why is that important? Well, cyclin D1 basically activates CDK4/6, which then phosphorylates retinoblastoma, right? And then when you do that, when it phosphorylates RB, it relieves inhibition of E2F that can then activate expression of numerous genes, right? So if you use Ibrance, okay, you use the CDK4/6 inhibitor like ribociclib, or you use abemaciclib, right? What you're doing is you're basically inhibiting CDK4/6, but in order for you to actually have a desired result, RB expression has to be intact, right? You have to have an intact RB because it still has to repress E2F. If RB expression isn't intact, it's a problem. And in 30% of liver cancers, it's not intact. They have mutations in RB1. So if you do a CDK4/6 inhibitor in those patients, it just most likely will not work. Here's some beautiful data kind of showing you what I just talked about, right? So in these patients, they basically had liver cancer cell lines. They looked at relative cell proliferation. They identified that if you added the plus sign, if you added the CDK4/6 inhibitor, you saw a reduction in proliferation. And so you can see that here in all of these cell lines, right? And so I thought that was compelling. You can see it very nicely here. You can see a reduction in cell growth with higher doses of your CDK4/6 inhibitors. They did this very nicely in preclinical studies. In addition, what they showed is if you had a patient who you gave the CDK4/6 inhibitor to, but they also had a defect in retinoblastoma, so Ibrance would not work or ribociclib would not work or what have you, what they found is, yes, that was true. Here's proliferation when you have an intact retinoblastoma. Here's proliferation when there's a mutation in RB1. And so you can see here that when, well, sorry, I shouldn't say mutation, when they do shRNA, when they basically abrogate retinoblastoma expression, RB expression, you can see that there was increased cell proliferation. You can see that beautifully here. When you have the shRNA to retinoblastoma, you can see an increase in the expression, or increase in cell proliferation. And so the last thing we're going to end with, we're going to end very soon now, I'm sorry we're running over time, is we're going to talk about targeting this R249S p53 gene in this protein, the resultant protein, and I'm going to turn over to Bhadresh Rami now.
Yes, thanks, Basam. Lovely. I think we have seen the unmet need. It can't be overemphasized more. And it's also not a surprise. If you see in the 9 patients that Basam showed the slides, almost all were from India, he mentioned. And if we look at the causality behind some of these HCC factors, there's a big interplay between aflatoxin B1 and Hep B infection. As many of you would know, aflatoxin is a toxin produced by fungus, Aspergillus flavus, that's generally found in poor storage of food grains. And when that is such a contaminated food is consumed, it's metabolized in the liver by cytochrome P450 into a toxic metabolite. That metabolite then further adds on and creates mutational response in the thing. And one of the things that's identified in HCC patient is these patients also have a guanosine to G2T mutation that is happening at codon 249, leading to the arginine to 249 serine mutation. The other thing that confounds in these HCC patients is the prevalence of hepatitis B virus infection, which kind of adds on top of the aflatoxin, if it's already there, is it creates a highly inflammatory context milieu in the liver, and the presence of oxidative stress in the hepatocytes, there has been seen an upregulation in the cytochrome P450 enzymes that further metabolize aflatoxin. So the two kind of act in concert. And what we see with these, when in this milieu in the organ, when this mutation is kind of promoted and almost selected, we see a fundamentally new signaling pathway that comes into play in the liver cells, which did not exist till then. What happens when the arginine at position 249 mutates into serine? Serine contains this hydroxyl group that starts to project, shown here as this little blobs on top of this protein here, oval. It becomes a new substrate for cyclin-dependent kinase of CDK4. So you have now a mutation that creates a substrate for a cyclin-dependent kinase. The phosphorylation of those serines through the CDK4 creates a phosphorylated version of P53 R249S mutant protein. This interacts with a protein called PIN1, which normally doesn't happen in normal physiology. The PIN1 bound R429S P53 protein becomes a substrate for nuclear import. It goes into the nucleus, it binds to c-MYC, stabilizes it, and then allows c-MYC to active and do its job, which is the growth of the cells. In addition, what is less known in this pathway is this other enzyme called SETDB1 that's involved in methylation of a particular lysine residue. And we also saw an interesting R249M mutation that Bassem highlighted much earlier. That's also methionine that's happening there. So that's not well understood. So two different changes happen concurrently when this mutation happens: methylation at position 370 and phosphorylation at the new serine at position 249. How the crosstalk is not well known, but what is well known is that there is a whole new signaling pathway that comes into play in these patients in the liver physiology that now can be targeted as a newly druggable pathway. And that, if we see in the next slide here, there's already evidence from labs at Tulane University that shows that if you now come in as a combination therapy, one is this molecule shown as PD, that's a cyclin CDK4 inhibitor that prevents the kinase activity of the CDK. The prevention of kinase activity would prevent the phosphorylation at 249 serine position. Concurrently, if you now go back to what we discussed earlier, is in the P53 field, this 249 mutation again happens in the DNA binding domain. So it's again a destabilizing mutation on its own, in addition to bringing in a new phosphorylation site. So it's a very complex biochemistry and mechanism that's happened. The multiple things caused by that one mutation. The protein gets destabilized, the new mutation, the new amino acid becomes a substrate for phosphorylation. The destabilization then can be reverted through the classical P53 stabilizer small molecule compound shown here as the CP molecule. That can stabilize the P53 protein to become more like wild type P53. The wild type P53 would then tetramerize, homotetramerize, and activate the pathway. And the prevention of the phosphorylation on top using the PD compound, the two act as a double whammy, and that leads to destabilization of the c-MYC and its degradation, which would then further bring down the proliferation of the hepatocellular cells in the carcinoma. This was very elegantly also shown that if you use single agents, either multiple concentrations of C1, that's your P53 activator, or P1, which is your cyclin-dependent kinase inhibitor, you don't get as much good response as you would see in the bottom graph. P2 plus C2, that's a higher concentration of both the P53 stabilizer and the cyclin-dependent kinase inhibitor. When you have both of them on the bottom left graph, the last little bar, you see the maximum inhibition of cell proliferation or cell confluence. So they do act synergistically. That's extremely promising for these patients. And that's the further, another readout of that on the bottom right is the c-MYC band on the very right side of the graph, where at higher concentration of PD and CP, the c-MYC is getting degraded, and that's another marker for ensuring that the cells are not proliferating. So this kind of a combination therapy that is very, very unique to the hepatocellular carcinoma, that is predominant in African, Asian, Southeast Asian countries, that comes from a combination of alcohol consumption, aflatoxin probably from the contaminated food grains, and also from hepatitis B infection. These tend to seem to almost select for this mutation, and the mutation is not a simple amino acid change, it's missense. It is leading to activation of a whole new pathway, but the pathway now having been tracked and elucidated well also throws up a synergistic combination of targets that can be targeted both as an activator of P53 and an inhibitor of cyclin-dependent kinase. Together hold tremendous promise in these cases to take it forward to actual human clinical trials, and hopefully that will reduce some of the disease burden in this case. It's a very promising field, but needs to be tested and seen. Thanks, Basim.
Bhadresh, that was amazing. Thank you so much. I have another talk I have to give in 1 minute here. So last thing I'll say is when you start to look at what companies like Illumina are doing with respect to precision genomics, you can see that they are very heavy in drug development now. It makes sense, right? They have all this data, can show these patterns in the molecular profiles like we showed today. They have an amazing advantage that they're now starting to utilize. And so you'll see a lot of these companies in drug development. Genetic counseling implications, really none to talk about here. And so these are concluding remarks. Listen, all P53 mutations are not created equal. That's really the take-home message today. When you see P53 mutation, please consider what the variant is. Consider if there's a targeted agent for it. Consider a trial for it. Second line onward for Unmet is an unmet need for small cell lung cancer. All of HCC is wide open, and consider some of these unique trials that we're talking about today. Thank you so much for your time. I'm going to go to Revolution Cancer now and give this other talk for the If You Were My Family Member sort of talk. And it's wonderful to have had everyone here. Thank you so much. I will get control of the timing issue. We're having an issue with time, and I'm sorry about this red line. Somehow that happened. So nice to meet everybody. So nice to see everyone. Thank you so much for your time. Please take care.
Yeah, thank you. It was a wonderful platform.
Thank you. Thank you, Basim, for this wonderful opportunity. Yeah, take care.